also Jean-Frédéric, working on digital health strategy and implementation. You've been thinking about workforce and how to support, access for staff through these things. Do you want to comment more on that?
Yes, thank you. When we think about virtual care, we often jump to the conclusion that this is just for patients. But the reality is that a lot of clinicians live and work with disabilities themselves. And virtual care needs to be something that becomes a tool for the clinical practices as well. It's really a technology that can help that interaction to be completely different in terms of clinical delivery. And I will talk a bit about it because there were two ideas or innovations that I wanted to bring to the table. But if I may share my word, my word was not really original. Because of the title of the session, it's accessibility. But I still wanted accessibility to be my word because, well, first, I was born in a very remote, isolated community in Canada. And, any problems for family members, including some of my family members with disabilities, were, the biggest problem was access to healthcare. Having to drive 12 hours to reach a center where there would be a specialist to see the specialist for sometimes 10 minutes and then have to drive back is not a great experience. And then professionally, working with refugees and also some experience that I've had in South India where I did my study, accessibility really has, then got to my professional life and has become a focus for me. And what I want to share now, yeah, you can see the slide. Really, my first point is that we need to consider access as a journey for anyone. And that journey, when we think about access, very often we just think about the clinical side of things, the opening hours, the cost of care, the types of treatment that you may be able to find in the practice. Previous slide, please. But the reality is access is determined by everyone's ability through that healthcare seeking process.
So I just want to point out the word on the slide is ability to, and we had like a lovely argument about this actually, just in our preparation session, because it's not about getting rid of the dis or anything naff like that and just seeing the ability, but in terms of access requirements and access needs, people actually need to have the ability to engage, like you're saying.
Absolutely, and every patient faces, they're facing many hurdles to actually obtain what's really relevant for them. It's about the ability to perceive your problem and think that you can be helped by the system. It's about the ability to seek healthcare, and we know that many groups will be discriminated, not being able to seek healthcare right from the start. Reaching physically is obviously a hurdle for many people. Ability to pay can be a big problem. And then even when patients are in the practice with us, the ability to engage, we cannot take for granted. Some people will have more difficulties to express what they truly need. So we need new tools to to make sure that clinicians can actually bridge those abilities and disabilities that people have across the entire journey so that they really truly receive what's needed. It's not just the patient's responsibility. The system has to adapt to those different abilities and the challenges that it poses for patients.
It's always made me just absolutely astounded that healthcare seems to be kind of one of the last frontiers in being more inclusive for people with health problems. Like I've been able to ask for, here are my access needs in other things, in other industry, the ABC's advertising looking for disabled talent because, it's not just nice, but Naz has touched on some of the advantages for employing disabled people. And in healthcare, it's like, you don't know where you can actually ask anyone for your access needs when you make an appointment. But I'll shut up again and show you your next slide.
Your point is very true, and there's a cultural element to it that we all need to work on to create that change. But there's two things I wanted to discuss more specifically, and there are things that we're really trying to do in New South Wales to improve access to healthcare and the appropriateness of care for people with disability, as well as the entire population. And the first one, of course, is virtual health. And we're really trying to accelerate virtual care during COVID-19, but also we've been working on many different tools that would help virtual care not just be a technological add-on, to clinical practice, because that's not really going to work. Having an outpatient clinic where some patients may come virtually and some patients may come face-to-face actually requires to have a different way to manage appointments, manage receptions, welcoming patients, the coordination with, lab tests and all of those things. So we need to think about virtual care as a redesign process. It's not just the technology, it's about redesigning the models of care, the way we work as multidisciplinary teams. And to do that well, we'll need to engage patients with lived experience, so that we, again, don't assume that with virtual care technologies, as clinicians, we know what's going to be the right solution to the problems that people are facing to access healthcare. So it's really going to be a journey where clinicians and patients need to come together, look at the available technologies, and then reinvent the way we deliver healthcare. The second idea, that's the next slide, is the idea of patient-reported measures. And it's either patient-reported experience, which is really about the way patients feel about their healthcare. Do they have continuity of care? Do they have to repeat themselves all the time when they come to see us? Do they feel respected? But it's also about outcomes, and I want to emphasize a bit more that point. Very often when we treat people with disabilities, we will look at the disability as being the main reason for complaint right from the start. It's the default setting. The reality is that people living with disabilities have various health problems or aspects of their health that they would like to be considered as part of their care. And what we're doing with patient-reported outcome measures as a program, and we are currently rolling out in New South Wales a system that enables patients before their appointment to reflect on various aspects of their quality of life. Do they feel a bit depressed today, or do they have more difficulty to move around compared to usual? What we want to do is for clinicians to have that information at hand when they're in the consultation room or on the ward with patients. And then they'll be able to, yes, address the diabetes or the specific health condition that from their own specialties clinicians come to the appointment with, but also have a broader view of the whole person and their needs. Because the reality is, even when we think about very visible problems or very specific health problems, we may find out that very often it's other aspects of quality of life that will truly make a difference for patients. And what we want to do is to really make it systematic for clinicians to access that information and be able then to engage in a conversation with patients and reflect on the current situation. How do you feel today? How can I really help you? But also reflect on progress on things. So that may prompt much better access to healthcare, because an endocrinologist may actually be able to see, okay, you're not moving very well right now according to what you're saying. Is there a way I should connect you with someone? Should we follow up with another provider that you're currently seeing, and really promote that appropriateness of care in the practice? Because too often we focus on the specific problem, and then we ignore the other things that will really make a difference. And so these are the two things I really wanted to emphasize today, because I really think we could do that. This is really concrete actions we could do, we could adopt in clinical practice, and that would really make a difference.
I think the important thing to note as well, that there are tools out there already to help with this. For example, a peak body that supports people, autistic people, Amaze in Victoria, has just put out a guide, and partly it's for autistic people to know the kinds of ways they can articulate what they're feeling, how they're feeling, their symptoms, either through a diary that they might keep or through storyboards or drawings or whatever it might be that suits them and their needs. But it's also for clinicians to read, to understand the types of perspectives that your patients are coming to you with. And so some of these tools are already out there and they're at your fingertips. They are there for you to use.
I think it's about focusing on what the patient wants. And touching on what Naz's story and also, the patient-reported outcome measures. As clinicians, we like numbers, how's the hemoglobin, is the K not too high, sort of thing. But it doesn't matter if, they've got a low hemoglobin, if they can't come into clinic because they're just too tired. The whole point of this is to understand the patient experience. And I know working with the ACI, with spinal cord injury, a lot of people out there think lack of movement is the biggest problem in spinal cord injury. Whereas if you actually ask patients, it's actually the bowel and bladder dysfunction. How can I get my bowels moving? How can I improve my bladder function? That is their main goal. So at the moment, we're trying to frame research to how to try to target these areas. But at the same level, clinicians, you have to know what is the most important thing. And maybe sometimes, they don't want to fix their movement. They actually want to fix some of these autonomic issues. So it's really important as clinicians to not just look at the numbers and actually look as a patient as a whole from a holistic sense.
Yeah.